So my topic today is human papillomavirus. We're going to go over just the basics first. So human papillomavirus is a DNA virus. The IARC, which is the International Association for Research of Cancer, has divided it into about 4 different groups. The most carcinogenic and most known is the groups that include 16 and 18. So 16 and 18 together, they cause about 70% of cervical cancers. HPV also has an overall prevalence of 20% among men and causes up to 50% of penile cancers as well as oropharyngeal carcinoma. HPV 16 is the subtype most common in that. So we have screening for HPV. The 2 main methods for screening for HPV is either through molecular testing to define the HPV virus and its subtypes, or through cytology where you can recognize the changes that have happened in the mucosal layer because of the HPV virus. Depending where you work or which country, different countries have adopted different methods. So this, for example, is an example of where France and Australia, Brazil, where they take HPV testing, molecular testing, as the first line to diagnose HPV. Other places, such as the United States, they do either co-testing, and before that, they used to do Pap smears. And the newer thing is that the United States Task Force in 2018 revised their recommendations, and now they can do either a Pap smear every 3 years or HPV testing every 5 years. And this is an indication of a bit of a trend to move away from cytology and more towards molecular testing. Review of the data shows that the sensitivity of cytology is actually less than doing a molecular test. So molecular testing has gone through a number of different stages, all the way from between the 1900s and the 2000s, until now, where we are moving towards next generation sequencing. It has also become more and more affordable. So you have low income options. And so, for example, here is the CARE, where they say they can even give the test for about $5 a test. So it's fairly cheap. And this is actually an at-home kit. So if you go into any pharmacy in the US, if you can afford to pay $60, you take the kit home, you test yourself. There's one for male, one for female, and you receive the results in the mail. And this shows just how much more easier HPV molecular testing has become over the time. We don't need to go into this detail, but there are a number of different companies that offer different methods. And I'll take this moment to say that molecular in general, it becomes cheaper the more tests you do. So it's better for example, IDCARE to maybe bring everyone together. We're going to all test in the same place, and that way it becomes cheaper for everybody. Now, cytology has been around for a very long time. We have here Dr. Bevis in 1927, and then the more well-known Dr. Papanicolaou, and his artist who drew the pictures, Hashime Murayama, okay? And both of them were the first ones to really recognize the effect of the cells with the process of cervical cancer. And actually in Romania, they refer it to as Babis Papanicolaou in recognizing that. Now, in 1988, you had the Bethesda system came into being to standardize the diagnoses. The idea is that whatever the cytopathologist sees, they diagnose it into a certain group, and from that certain group, the clinician will know how to treat. So these were the main groups: the negative, the ASCUS, which is atypical cells of uncertain significance, low SIL, ASC-H, high grade, and malignant. In order to process cytology, there's a number of different methods. The 3 main methods are ThinPrep, SurePath, and conventional. These are different companies. So ThinPrep is owned by Hologic, and there's a number of limitations, particularly in environments like in Egypt, where it's more of a limited resource, where you have to not only buy the equipment, but also buy the ancillary equipment, such as slides, such as digital scanners, etc., which makes it a very expensive process. SurePath is an option as well. However, SurePath is not as good as ThinPrep. Okay, so ThinPrep is better than conventional staining by about 20%. So let's talk about conventional staining. Conventional staining is basically the clinician takes a Pap smear, spreads it on the slide, and as it is stained with a Pap stain. Unfortunately, the problem with this is that the cells are on top of each other. It's very difficult to see, as well as an incredible amount of blood in the background. So I like to add the fourth method to this, which is something called a rehydration method. And the rehydration method is very simple. The idea is that instead of fixating in alcohol, it's left to dry and then washed off with saline, and then fixed in formalin, and then alcohol fixed, and then you do the Pap stain. And what that does is that it removes all of the background blood and increases the visibility, in some studies up to 20%. And I recommend in all of the institutions here who are doing cytology, please consider using the rehydration method as a way to increase the visibility. Now, these two together, they get incorporated into management. Each country has a different way of approaching. So I'm obviously not going to go through all of the different management scenarios, but we can say, like in the US, if there is a patient with a positive HPV, what do? They do a colposcopy. What if it's negative? Then they repeat the co-testing, right? And if there's no HPV test with the ELSA, then they do a colposcopy. And you can go through the different management of the American Society of Colposcopy and Cervical Pathology. Each one has a different scenario of the result of the cytology versus the result of the HPV molecular testing. So now let's talk about the vaccine realities. This was a major breakthrough when GSK came up with the bivalent Cervarix, which is mainly focused on 16 and 18. And now we have a Gardasil 9, which is part of Merck, which has all of these as well, which is 6, 11, 16, 18, and many more, which includes a number of the low risk ones that cause like genital warts, and then the other high risk. The general current recommendation is that it is given for routine vaccination at age 11 or 12, even starting at 9. And then there's another like makeup time between 21 and 26. And even after that, up to the age of 45, especially in high-risk groups. And this is why it's so important that we have pediatricians with us in the audience, because they will see these patients, these individuals early on, and can give them more of an awareness about it. The problem with this is the cost of the dose. So the cost is from $97 to $120 a single dose. And if you look at the map of where there is actually vaccinations, you'll find most of them are in affluent countries. Okay, that's the green. And then the Gavi Alliance took care of the lower income countries. So the Gavi Alliance was a very nice effort, which came from everybody. It came from WHO, UNICEF, CEO, etc. And what they did is they managed to offset the cost so that it would be $5 a dose. And so this is one place where I think if everybody worked together here at IDCARE, we could request maybe a Gavi for middle income countries. And this is actually confirming a bit of what Dr. Kausa said about the pneumococcal vaccine also, which is now available through Gavi for low income, but countries like Egypt don't qualify for the Gavi Alliance. Definitely funding would be a major step through. HPV burden in Egypt was actually very interesting. And to understand it, we have to compare it to the global spectrum. So globally, cervical cancer, which is caused by HPV, like we said, 70 to 80% of these cases are caused by HPV. It's the fourth leading cause of cancer in women. The disparities between the global is very evident. So over 80% of cervical cancer currently occurs in low and middle income countries. The rates are 7 to 10 times higher in Africa and expected to increase even more. Okay, more than 100%. And in comparison, a country like in places like Europe, it's expected to decrease. So on the one hand of the spectrum, you have this from the BBC News last week, hopes raised for cervical cancer eradication. And it's interesting they use the word eradication. It's a bit of an exaggeration. But this was based on an 8-year study which showed the extent of the success of having both screening and immunizations together. And then we come and look at this kind of area where we find that, for example, like I said, Europe, it's minus 3% expected to grow by 2040, and then areas like Northern Africa, more than 83%. So this is from something called Globacon. These are the countries that have a screening program. So official screening programs in the Middle East, we can say there's Tunisia, there's also the Emirates. And the rest are, once again, most of them are affluent countries or countries that have funding as low-income countries. And now we're going to talk about cancer, cervical cancer in Egypt. So GlobalCon, which is, like I said, the IARC, and they follow the the incidences and prevalences of cancer. And so here we have Egypt, for example. We have that it's expected by the year 2040 to have increased by 84.9%. The Emirates is expected to increase by 229. And then somewhere like, for example, Israel expected to increase by 40%. So there is quite a variation. According to also to GlobalCon, HPV is the main cause of infectious disease-related cancers in Egypt, more than hepatitis C. Here you have the MIN. Hepatitis C is obviously first in line. Now, the problem with this data is that GlobalCon used mainly this source for their data. And this source was the beginning of a national population-based cancer registry program. And I'm not sure why it didn't continue, but the source was mainly from three areas, so Aswan, Dumyat, and Minya. Unfortunately, the two largest cities, which probably have the most of the higher risk groups, Cairo and Alexandria, were not available. Their other source of data was from nearby countries, and once again, you have Sudan and Libya, who do not have national registries to compare with. And so there's a possibility that this data that we see is actually not clear. Now, I did a literature search, and I found quite a variability. So you have some areas like Mansoura, which described 52.63% of the cervical cancers were caused by HPV. In comparison, you have from the Ain Shams University and the National Cancer Institute, where they described up to 98 and 93% were caused by HPV. And so there's a question, is there a possibility that in Mansoura, the causes of squamous cell carcinoma in the cervix are not related or less related to HPV? That's possible. And then we discussed, for example, the oropharyngeal carcinoma, and this came out of the NCI here in Cairo as well, where they found about 40% of tongue and lip and oropharyngeal carcinomas were also related to HPV. Now we're going to touch base a little bit on the risk factors in STD, and I'd like to thank Dr. Musa for bringing up about the HIV, because they are very similar in their factors. So the idea of HPV is that a lot of the times it comes in the body and it's cleared out. The problem is when there's a persistent infection, and they have found a number of risk factors which lead to the persistence of this infection enough time to cause a change into cancer. One of them is alcohol consumption. If you see the alcohol consumption from 97 to 2015, it's almost just above 2.5 liters, which is above the national average. And I thought this was interesting because this was from the Pharaohs, and they're telling people to don't drink too much because then you will be kicked out and blah blah blah. And it was very very nice, but it shows how well aware even back then excessive alcoholic consumption is probably not a good idea. Now, smoking is another area which causes a persistence of infection, and we don't need to even, we all see the extensive amount, males more than females, of smoking that's available. Now, we're going to talk a moment about HIV. So HIV, this was the task force for HIV in 2010, and this was a more recent article that came out in 2014. And the result of this article was that even though Egypt was considered a low-grade epidemic country, now it's moving towards a more concentrated HIV epidemic. And this is an issue because HIV and HPV have a synergistic effect. So if someone has HIV, it is very likely that they will increase. Now, the problem is also with the general behaviors, and this is something that Dr. Musa also mentioned, is that these high-risk groups also have relationships with people who are not part of that whole system. So, for example, the men who have sex with men, 40 to 86 for them also were married or had female partners. And you have, for example, people like street children, drug users, all of these are people who are considered high risk. The other problem is really the response of the health sector towards these patients who have HIV or these high risk groups. And this paper showed about HIV and AIDS stigma in Tanta University hospitals, and at least almost half of them preferred not to provide medical services to these high-risk groups like the drug users, the homosexuals, or HIV. And this is something that definitely, if there was more awareness, more understanding of infection control, and just a general understanding of the treatments available, that would be very helpful. The government also, the rule, these were national guidelines for the management of STDs, and HPV was not even mentioned. And last of all, we have a high-risk group of refugees. So Egypt is actually the pathway for a number of like human trafficking pathways, and is also the home to like about more than 187,000 refugees. And obviously, this is a vulnerable group that is more exposed to these risk factors. Now, there's two other things which are not very clear what their extent or their impact are. One of them is waterborne contamination. It has not been proven that HPV can actually be transmitted through the water, and it's not likely. However, when Dr. Hamza checked 3 of the water treatment centers, he found HPV 16 and these other lower risk types in about 30% of the examined water. So this might be just an indication of its prevalence within the environment itself. And the other question is schistosoma synergistic with HPV? And there was a couple of studies from Tudor Bilharst that showed that, and unfortunately, but at the same time, there's a number of studies from other countries which have not shown it. And so this is an area that maybe needs to be explored in more depth. Now, I'm just going to mention attitudes and the UAE experience. So United Arab Emirates is the only country that has done an extensive program for screening and for immunizations. And I found it very interesting. The way they began is really through the media. So awareness is a very important step forward. The media plays a key role. Since their population is a mixture of both Arabic and English, they had a huge number of papers that went out about 6 years before they actually launched the HPV vaccination campaign. So you have from 2001 through 2007, you have a few articles, about 7, about this number of articles. And then after that, they continued to do these articles. The majority of these articles were about the programs themselves. So the screening programs, the vaccination programs. And the second thing right after is statistics, because when people can see the statistics of how much of a risk it actually is, then that's a good way of approaching it. And like I said, they did English and Arabic because they have a bilingual population, obviously. And this was an example, for example, of an English paper, while this is an example of Arabic, right? And so we can learn a lot from the Emirates experience. And this was an interesting paper where they actually analyzed the knowledge, awareness, and accessibility of a vaccination program in the Middle East and North Africa. And they found that there was a general lack of knowledge, which is not surprising. But there was also a very strong interest in learning more about the vaccine, along with a willingness to get vaccinated or get their daughters vaccinated once they were aware of the risks and how it could be protected. And here they showed how the different intermixing of knowledge, attitude, and beliefs and risk perception could interact together towards a final goal of having either the mother guide the daughter to have the vaccine, or the woman herself getting the vaccine. And so I'd like just to conclude by saying human papillomavirus is a very serious infectious disease here, and I'm hoping that we can bring awareness to this topic. Tomorrow we will be in Fayoum Oncology Center. Dr. Kausar Talat will be speaking about the vaccine in more detail, and I will be speaking once again about screening and prevention. And we'll be also talking about cancer cervix treatment and management by someone, Dr. Ahmed Sikatori, who has been working with this for some time here in Egypt. Thank you.